Hello everybody, my name is Kerry Payne. I'm named Nurse Safeguarding Children for the organisation. Today is the second champion event of the year. Today's session will be focusing on safeguarding children, but you will also receive an update from an adult, maternity and lack perspective. Please disseminate this information far and wide amongst your teams, and I look forward to seeing you in the near future. Thank you. See you soon.
So I just want to give you an update on the safeguarding team structure. So as you can see from the poster, you will be familiar with many of the staff in position currently. But since this poster was devised, there has been further changes. So Dr. Rona McCrone is now the named doctor for South Tyneside and Sunderland. We have a new safeguarding children advisor, that is Vicky Gray. And we also have a new lack and young persons nurse, and that is Vicky Button. So there'll be various opportunities to meet the team as they come around your ward's departments, or you speak to them via duty if you need any support and advice on any safeguarding cases, or if you receive safeguarding supervision. This slide gives you an overview of the number of referrals that have been made from the organisation from the 1st of April 2019 up to the 31st of March 20, so a full year of data here. As you can see, a total of 1,558 referrals were made. That's a 7% decrease from 2018-19, and I'd like to think that this is because we are making more appropriate referrals to the local authority by using the threshold documents. Each local authority has a threshold document which you'll find on the Safeguarding website. Please use this as guidance when you make a referral to whichever local authority. So as you can see, Sunderland Royal Hospital referrals, there was 1,025 referrals made within that year. From South Tyneside Hospital, there was 515 referrals made. So most of the acute referrals are in relation to parental mental health, parental substance misuse and domestic abuse, and also child mental health. They are the main themes of referrals from the acute areas. From the community perspective, there was 182 referrals made within that year, and the main reason for community referrals tends to be neglect. Maternity referrals from Sunderland Royal Hospital was 307, and from South Tyneside there was 93. The main reason for maternity referrals tends to be information pertaining to parents' history, historical concerns, i.e. previously they've had children removed from their care, or children have been subject to child protection plans and there's a subsequent pregnancy. Another common reason for maternity referrals is concealed pregnancies. So I want to talk to you a little bit about what's been going on during the month of COVID-19. So the previous data that I've quoted there ends on the 31st of March 20, after which we were in the height of COVID-19, and we did see a reduction in our referrals made to the local authority, and the reason for that has been twofold. Firstly, there has been a change in service delivery in line with COVID-19 government guidance. So we have needed to change some of our services, particularly our community services. So that has meant, unfortunately, that children haven't been seen face to face as much as we would like to. Also, we did see a big reduction in A&E activity, with not as many children being brought to hospital, both of which has impacted on the referrals. As children have returned back to school, we are now starting to see an increase in activity and referrals returning to the levels that we'd seen pre-COVID-19. We've seen a change in some of the themes of referrals during COVID-19, and certainly seen mental health as a feature of many of the referrals that have been made from accident and emergency attendances, and that is mental health from both parents and carers, and parents looking at alternative coping mechanisms of the stress that they're under, and sometimes that's been in the form of alcohol and substance misuse. We're starting to see a change in the way that exploiters are adapting their tactics to avoid detection. So this slide talks mainly about exploitation and some of the current trends. So we're starting to see an increased use of taxis and ride shares in order to traffic young people for the purpose of exploitation, either from a criminal or sexual point of view. Supermarket, car parks and public spaces have been used for deals and as a place of hangout for young people. We've seen an increase in cuckooed addresses as activity moved indoors. Cuckooing is a safeguarding term, and that is when a vulnerable person's home is targeted as a base for drug dealing and criminal activity. This is known as cuckooing. Young people are being groomed and exploited locally instead of being made to travel long distances. We've had reports of people being dressed as key workers to address detection. And what we want is you just to be more alert to changes in models of exploitation and share any new trends or patterns appropriately. So you can share information through force intelligence, you can share information via the safeguarding team, and you can share information via 111 Crime Stoppers. If you need any further advice, then please contact the safeguarding team. So what can you do as professionals during this very difficult time? What I'm going to urge you to do is utilise your safeguarding training. Use your years of experience here. Professional curiosity goes a long way. Be curious, ask them questions, be brave, speak to young people. They tell us they want you to ask. They want you to ask about their home situation, about school. Some of you may have heard of the HEADS template that we use within the organisation, mostly used within accident emergency areas, but this can also be adapted to for use within the community. So ask about home. Who do they live with? How's things at home? Are they happy? How's things at school? Are they attending school? Alcohol? Do they use alcohol? If so, how often? Who buys it? Their diet, any drug use, self-esteem and sexuality, often the question where we don't want to go, we don't want to ask about, and safety and suicide. That's what HEAD stands for. It's a really useful tool, and I urge you to use that within your everyday practice. We've also got MARIC, the risk assessment tool we use for MARIC, to determine the level of risk should there be a disclosure of domestic abuse. And also there is a tool for MSET of determining the level of risk if we're concerned about exploitation. Utilise information that's available to you. Speak to your health colleagues. Look at Meditech, look at EMIS and what flags are currently on there. Is there a child protection flag? Is it a looked after child that you're dealing with? Is there a MARIC flag? Speak to your safeguarding team. Obviously information stored on different systems within the organisation, but your safeguarding team should be able to advise you if there's been any historic information and concerns about the family that you're looking after. And also there is Great North Care Record, which I'll come on to a little bit later, which can also inform your decision making. Signs of safety. Signs of safety has been discussed in previous champion events. This is a strength-based model, Centre Safety is used within Sunderland, and strength-based practice is used within South Tyneside. But this is about capturing the voice of the child, looking at the strengths and concerns and what missing information, and supporting the family to pull upon what support factors they've got within their own family and community. Voice of the child, always important within safeguarding, but it couldn't be any more important now. Like I say, we don't know what's going to happen in the months to come. It may be that we have another lockdown and educating children. We're not seeing children as we have done within previous months. And sometimes we just need to think a little bit different about how we are speaking to young people, whether that's texting, whether that's through a virtual means. But we do need to be speaking to them and making sure that we're asking them the question. And if we've got them in front of us within an accident emergency environment, then please utilise that contact. Every contact counts. Consider early help. Prevention is far better than cure. And again, like I mentioned earlier, we've got threshold documents to help support your decision making and what criteria is needed. Is it early help? Is it child in need? Or is it safeguarding? The threshold documents are there to support you, as well as the safeguarding team as well. Signposting. We send you a wealth of information as a champion. Please harness that information so when the time comes when you do have a disclosure, you've got information at your fingertips of knowing where to signpost families for help and support. I've already spoke to you about the risk assessment tools, all of which are found on the Safeguarding intranet page. And lastly, safeguarding supervision. Safeguarding supervision will always be a priority of the organisation and the safeguarding team, and it is imperative, particularly at this difficult time, that you receive safeguarding supervision and you discuss cases within a science of safety format. Just continuing on the subject of safeguarding supervision, it is the duty of healthcare organisations to ensure that all health staff have access to learning opportunities via safeguarding supervision. The Trust does have a safeguarding supervision policy, and I've put the link for your reference there. There is a matrix of who is assigned to safeguarding supervision and the times in a year that you need to have safeguarding supervision, and that is also recorded on your ASR compliance. If you do not receive mandatory safeguarding supervision, you can still contact the team to arrange a safeguarding supervision session to discuss a case. Safeguarding supervision is available to all staff within the organisation, regardless of role. Safeguarding supervision has and will continue to be a priority of the organisation and the safeguarding team. Obviously, the arrangements for supervision may need to change depending on government guidance at the time. Group supervision sessions may need to be smaller to accommodate social distancing, or wherever possible delivered through Microsoft Teams. So I'm urging all departments to have the IT available to them in order to comply with their safeguarding. If safeguarding is mandatory, the data is reported to department managers and CCG. Just to give you an update, compliance for Q1, maternity community supervision was 98%, maternity hospital supervision was 83%, and all group supervision sessions were 100%, and one-to-one sessions again was 100%. So I thank you very much for engaging in the process here. So I just want to give you an update on drug and alcohol support services for young people. In South Tyneside, we've got the Matrix service, which supports young people under the age of 18, and I'll give you the telephone number there, which is 0800 328 1898. You can now make referrals via Meditech. WIDAP is the equivalent in Sunderland service for young people under the age of 18, and the telephone number for that service is 0191 561 4000. Again, you can make referrals to this service via Meditech. Both services are now an opt-out service. You do not need consent from a young person to refer to these services, but we would expect that a discussion is had with the young person prior to making the referral. There is a leaflet available on the Safeguarding intranet, which has been devised by our young persons group within the organisation. So we have captured the voice of our young people. Latest developments is we have secured funding from the CCG for 6 months for a drug and alcohol worker to be contracted to work within Sunderland ED on Friday evenings and weekends. As we well know, this is the time when young people will go out and experiment with drug and alcohol. Research has proven that the uptake is far better if we are able to address the problems whilst the young person is within our accident and emergency department. So if this is successful, it hopefully will become a permanent thing for the organisation. The Great North Care Record is a way of sharing information with health and care workers. It covers 3.6 million people living in the North East and North Cumbria. The Great North Care Record is available to you on Meditech. You open the patient you have selected, press summary, and GNCR link should be at the bottom of the screen. If it is not, please contact the IT department and they will give you permission. The information that is contained within GNCR gives you GP information and mental health information in regards to diagnosis, treatments and care plans. The link that I've supplied on the screen gives you more information about GNCR. This is a great step forward in terms of safeguarding and information sharing. So I just want to give you an update on child safeguarding practice reviews, formerly known as serious case reviews. There are 4 active cases in Sunderland and South Tyneside currently. Baby Kate serious case review has just been published from Sunderland Partnership. That was published in October, and Lee McCallum will give you a 7-minute briefing on the following slide. There's an ongoing CSPR in South Tyneside, which is Child J, and we should have that published by December this year. Any future learning will be shared with you in due course.
Hello, I'm Lee McCallum from the Children's Safeguarding team. In this section of the forum I am going to give you an overview of a case from our trust and learning points identified. You should now see on the screen a 7-minute briefing. This 7-minute briefing looks at the serious case review of baby Kate. The background of the case of baby Kate was that she was brought into hospital following a significant head injury. She was 10 months old at the time and died as a result of the head injury. The parents' explanation of mechanism of injury changed, resulting in police investigation as to cause of injury. The purpose of the serious case review is to establish what lessons are to be learned in respect of how professionals and organisations work individually and together to safeguard children and young people. It is also to identify any changes to inform national and local policy. The family were previously open to children's services on a child protection plan under the category of emotional abuse. Baby Kate had one full sibling and 4 half siblings. Mother and father were both in Baby Kate's life, but 2 weeks prior to her death, Baby Kate and some of the other children were living with Baby Kate's father. Further information on the family is that in March and April 2016, 3 incidents of alleged domestic abuse had led to the case being brought to Initial Child Protection Conference. This was in relation to the siblings, as Baby Kate had not been born at this point. Domestic violence has been an issue in the family since 2002. This has been reported by older children, which led to the elder sibling leaving the family home. There was also ongoing concerns regarding parental substance misuse. We then look at the key learning points of the case. While the exact circumstances of Baby Kate's death remain unclear, domestic abuse and disguised compliance were identified as key themes throughout this review that led to the context in which such a tragic event has occurred. The difficulties of disguised compliance, especially within a domestic abuse context, were highlighted throughout. Practitioners did show an understanding of these, but when identified that the systems and practices struggled to deal with the true nature of domestic abuse and the dynamics of coercive control. Recommendations from the Serious Case Review are as follows. Actions generated within the Child Protection Plan needs to frame to reflect expectations outcome of work undertaken, with a focus evaluation of risk, for example, re-examining the perpetrator's attitude towards domestic abuse rather than solely on their attendance to programmes. Learning from this review to be shared by Sunderland CCG for considering by individual practices around the way in which information regarding adult patients are shared, where relevant, for consideration with ongoing safeguarding children processes. Work being undertaken within SSCB around the development of a clear approach to domestic abuse should aim to ensure that all staff have an understanding of coercive control and that tools are available, processes in place that support practitioners. South Tyneside and Sunderland Foundation Trust did learn and implement changes following Baby Kate's death. The Trust have now got a red flag system and indicators to highlight and inform staff. This includes MARAC alerts. This gives staff a prompt for further questioning. Mother did attend the ED on 2 occasions with injuries at the time. Explanations were given and felt they would match the mechanism of injury. While there was nothing to say that was not the case, in the light of a concern about domestic abuse, it raised the question about whether the hospital knew about the history of domestic abuse and child protection concerns. Safeguarding selective enquiry has now been added to Meditech to prompt for further questioning. This is asterisk so that staff must ask the safeguarding questions. Signs of safety has been implemented within the Trust. This is an innovative, strength-based methodology to child protection casework that aims to build up families. This is also used on our DATIC systems where staff are submitting safeguarding referrals. Thank you.
The next slide you see in front of you is the maternity update, and this is with regards to the promotion of the Safe Sleep campaign to prevent sudden infant death syndrome or cot death. You will see in front of you the figures which suggest that there has been a rate increase which came from a study in 2018, and that report stated that maternal age is a risk factor for infant mortality. The report suggested that the SIDS rate was highest for mothers aged under 20 years, and this has remained constant since 2005. So as a professional working with parents or carers of young babies, we should be all giving the same consistent message, and that is 3 key pieces of advice will be to put babies on their back for every sleep, and this should be consistent from day 1, in a clear flat sleep space, on a firm flat mattress, so no pillows, duvets or bumpers, and they should be kept smoke free day and night. Research will tell us that the risk of SIDS is 10 times higher if a baby bed shares with a smoking parent. It is also important for all parents to be made aware of the risks of falling asleep with their infant on a sofa or armchair and to avoid this. We have in the past had serious case reviews which have shown baby overlay, and therefore this is a huge learning curve for us all. There is evidence from many long-term studies of sudden infant death that some of the infant deaths associated with bed sharing and other risk factors could have been prevented. There is no advice, however, which guarantees prevention of sudden unexplained deaths, but the risk of SIDS can be reduced considerably if the reduce the risk advice or safe sleep is followed. So we all know that parents make decisions on safe baby care. So for example, it will be about where they want to sleep the new baby, what bedding to buy at different times. Therefore, it is vitally important for midwives and other professionals working with parents during pregnancy to target parents with the safer sleep message as just discussed. This advice should be followed up by the midwife after the birth and again by the health visitor in the early weeks of the baby's life. It is essential that all professionals in touch with parents and visiting the family home make sure that the messages are understood by them and do not assume that someone else has already offered leaflets or other materials. And it is vitally important that we continue to discuss safer sleeping with parents even where their choice is to bed share, and all we can do is record the advice given and the parental responses. So on every occasion where safer sleeping advice is given or the infant sleeping arrangements are assessed, we should always write this in a written record to keep a copy of this for future reference. For further advice and tips on working with young parents, you can see information on the YouTube clip, which is direct linked to this video, and also the Lullaby Trust has a lot of information on the Safer Sleep Saving Lives, which continues to promote the campaign and also has a lot of information not only for professionals but for parents as well.
Hello, my name is Vicky Smith and I am lead nurse for Looked After Health for South Tyneside and Sunderland Foundation Trust. South Tyneside and Sunderland's Looked After Health teams have now come together as one team, and we are all based at Durham Road Children's Centre. The team's role is to assess the health of children coming into care and review their health on a 6-monthly or yearly basis depending on their age. Children under 5 years will receive a health assessment every 6 months. Those over 5 will have their health reviewed yearly. There is evidence which suggests that children in care have poor health outcomes over their lifespan. The health assessments ensure that any health needs are identified and met. These needs are transferred into a health action plan which is formulated with the child or young person and shared with their care team. This ensures that as corporate parents, their team and us will support them to achieve their full potential. Unfortunately, Sunderland and South Tyneside have double the national rate of children in care. Currently, there are 941 looked after children in Sunderland and South Tyneside. This is 623 children in Sunderland and 318 children in South Tyneside. A child in care is defined as one who is in the care of or the joint care of the local authority and is under 18 years. After 18, young people are identified as care leavers and they are entitled to support from the local authority until their 25th birthday. Meditech will indicate if a child is in care. This is indicated by the red box in the left-hand corner of the record. When you hover over that, that will state when a child became looked after, or indeed when they have left care. Once they've become a care leaver, the information will remain on their Meditech record. Due to looked after children's childhood experiences, children in care have a number of vulnerabilities. They may struggle with their mental health or behaviours. They may have learning difficulties or delay. They may misuse alcohol or substances to cope with their experiences, and like many young people, they may participate in risk-taking behaviours which leaves them vulnerable to exploitation, as Kerry has discussed earlier. I do wish to highlight that many looked after children continue to have contact with their parents. This may continue to impact on their health and well-being. Looked after children and COVID. Completing health assessments for children in care is a statutory requirement. During the initial lockdown, many looked after health teams nationally were redeployed and face-to-face health assessments were suspended. This created a challenge for the department, and with our partners we developed a COVID testing process for children in care. This was associated with the fear within the community and foster carers about being able to quickly place children coming into care, and the fear from carers and care providers that we would be placing children who were positive. We managed to work through this, and we advocated that children weren't routinely tested unless they were symptomatic, and this was taken on board across the caring community, so that it was very positive. In view of face-to-face appointments being suspended, a telephone triage assessment was implemented, especially for initial health assessments for children coming into care, where we are very unclear about what their health needs are. A telephone triage allowed the practitioner to gain an overview of the child's health and well-being, and should there be concerns identified within that consultation, children were brought in under strict infection control procedures and thoroughly assessed via a face-to-face appointment. Review health assessments were completed mainly online, on telephone, and this was effective to a degree, although all of the team found this challenging because you weren't able to fully engage the young person. It's difficult, as we all know, that in communication, much of communication is through non-verbal communication. We developed a restoration plan, and the trust did take it on board about the importance of reinstating face-to-face health assessments as soon as possible, and clinic space was secured so we could return operationally. As part of the service, we wanted to understand and develop some feedback from our young people, particularly around telephone health assessments and also around their feelings of being a looked after child during lockdown. This had a positive response. It was a small study, but we did get a very good response from the young people, and it was a unanimous response that these young people really did want to be seen in person. We thought as a team that they would be quite happy just to have a telephone conversation about their health, but they really felt that they needed to be seen face to face, and they called this for a proper assessment. One young person did say that they wanted to see the nurse's face to make sure that they were listening and that they were documenting what they were saying properly. The children missed their peers. However, for some looked after children, they'd enjoyed the lockdown. They enjoyed the fact that they received more family time, that they were contained within a family home, that they were given attention. There was only one young person of those 15 who admitted not adhering to lockdown measures. We managed to return the service to being fully operational in mid-July with infection control procedures, which, as you can imagine, is relatively challenging when you're trying to assess the health and well-being of children and young people who don't want to sit still and want to play within the clinic environment. We're continuing to offer that until we're told otherwise. Please can you remember that should you have any concerns about children in care, to contact the Looked After team. We're here Monday to Friday, 8:30 till 5. Thank you.
Hi, this is Conor Dooley, Safeguarding Adults Advisor. Safeguarding Adult Update. Referral activity for July and August. There were 106 safeguarding referrals made by acute staff, with 38 referrals made by community staff. All themes were in relation to neglect, self-neglect, domestic abuse, physical abuse and financial abuse, with 237 DOLS applications made by trust staff. So with an update on MCA DOLS guidance, 7th of September 2020, the Mental Capacity Act and Deprivation of Liberty Safeguard during coronavirus pandemic has additional guidance added. The update does not change the current COVID-19 DOLS process, and local authority best interest assessors and Section 12 doctors will continue to assess remotely. It does reflect the need for an MCA 1 assessment and an MCA 2 best interest decision making on behalf of those patients who are assessed not to have capacity to consent to elective surgery and other procedures. Staff are to ensure that any patients who have adults in place have the opportunity to communicate with their relatives via virtual technology or a telephone to reduce the risk of further restricting their liberty.
Hi, it's Sharon Walker, Safeguarding Trainer, and I will be talking about training compliance at this forum video. So our training compliance, as you know, has a target of 90% across the trust, and we remain on target across both adult level 1 and 2 and our children's safeguarding levels 1 to 3. So a big thank you to everybody that has continued to complete training as required. As you will have known from the last forum video, we were about to introduce Safeguarding Adult Level 3 onto staff ASR. This has now been introduced, and since the introduction, we have achieved just over 50% of staff completion. What I would continue to do is urge you as a champion to inform staff that if they do see this on the training matrix, they complete it at their earliest convenience, and also if any other training is out of date, then to please bring this up to date. This next slide is just a further training update, in that all of our face-to-face training sessions remain suspended, and this is until further notice due to COVID-19. Our e-learning of course continues in its place, and again this will be until we have worked out in which way forward we will be going and whether this will be e-learning or a virtual platform. We do have a safeguarding newsletter which is provided, and this gives further safeguarding updates, and hopefully you should have all received this by now. If you have not received a copy of this, then please feel free to get in touch with the safeguarding team and we will ensure that you get sent a copy. However, we also have this as part of the Trust Staff e-bulletin. Further information around training is short courses are also available through our safeguarding partnerships and adult boards, and again these are usually sent out to yourselves for distribution. So if there is any staff member who is interested in any of the virtual sessions that are going on currently, then please feel free to join them or enrol and take part. COVID-19 has been and continues to be an extremely challenging situation for all of us. We are significantly changing the way in which we all work, hence the reason for this video and not a face-to-face forum. However, as a team, we recognise the importance of your role as champion, And the development of safeguarding champions for adult and children, including MCA champions, was put in place to enhance and streamline safeguarding practice. And the team recognise that in order for you to fulfil your role, you must have the full support of the organisation and your direct line managers. And what we are currently doing is looking at our terms of reference, and this was initially sent out to all of you at the beginning of last year. And we are continuing to look at further recruitment of any staff member who has a keen interest in becoming a champion. We also would like any suggestions as to how you would like to see things going on in the future with regards to Champions Forums, if there was any particular kind of information or anything that you feel as a champion you need more information on. We would be very interested in this. Going back to the terms of reference, this will continue to contain information on your role. It also requires a signature from yourself and your managers or leads, which will show us that commitment in recognising that you will need time to be able to either take part in or view a video in order to receive information that you can then feed back to your work colleagues. So you would need time and to be able to digest this, and this is something that we ask all managers and leads to commit to. So when you receive this term of reference in the next few months, could you please return the back signature page to us, which will have your signature and your line manager's signature on, as this is used for evaluation and reporting purpose. What I can say is that when I did send the last term of reference out to all champions, the return rate was fairly poor, of less than 50%. So it is very important that when you do receive the next updated term of reference, you send this back to the team, please.
The long-term plan advises that organisations should strategise their digital technologies. So in response to this, and also as a team to enable us to have a consistent and standard approach to safeguard and referral activity, we've incorporated a new safeguard and referral system into Datix. So that went live on the 1st of July. So now if staff need to make a safeguard and referral, they can do so through using the new safeguarding module within Datix Instant Reporting. It's accessible to all staff when they log into Datix. And in order to log into Datix, you just use your usual network name and password at the top of your page. The referral is then completed by the inputter, and then that is emailed securely by Datix to the relevant local authority. This next slide shows you a screenshot of the Datix module. And in order to submit your safeguard and referral, you would click on the Safeguard and Referral tab. This will then introduce you to the questions that you need to populate your safeguard and referral form. I'd just like to end with the main key message, which is safeguarding is everyone's responsibility, but don't feel like you're out there on your own. The Trust Safeguarding team's there to support you in raising your concern, and we can also provide you with advice and supervision. This slide provides our team contact numbers for both adults and children's safeguarding teams and maternity team. So we've got our single point of contact for South Tyneside, it's 202 4135, and we're based next to pathology. It's Sunderland, it's 5410555, and we're based in M1 next to cancer services. And our looked after team are based at Durham Road Children's Centre on 569984, and we work Monday to Friday 08:30 to 1700 hours. So please get in touch if you've got anything that you need advice and support with, and we'll be more than happy to help.